I'm so pleased to introduce Dr. Sharlene Day, who will be giving our grand rounds today. Dr. Day graduated from MIT, then med school at NYU, then went to University of Michigan for fellowship, where she joined the faculty and stayed until last year when she moved to the University of Pennsylvania as the director of translational research. Her research has focused on hypertrophic cardiomyopathy, with interest ranging from the molecular mechanisms, specifically the regulation of myosin binding protein C, to clinical issues such as predictors of disease progression. While many in the field of hypertrophic cardiomyopathy have focused on hypothesized dangers of exercise, which is largely a data-free zone, Dr. Day is unique in looking very systematically at the benefits of exercise. This is how I met her, very pleased to meet a kindred spirit, and we've gone on to collaborate on a large prospective registry. Dr. Day is well recognized in the field of hypertrophic cardiomyopathy. She serves as associate editor on multiple journals, including European Heart Journal, NIH study sections, and on the leadership committee of the AHA Genomics Council, and most recently on the writing group for the recent AHA guidelines on HCM. I'm so looking forward to your talk, Sharlene, so we'll get started. Thank you.
Rachel, thank you so much for that very generous introduction. It's such a pleasure to virtually be here. Of course, I wish I could be here in person. We would have had a really fun dinner last night. So, I've been very passionate about hypertrophic cardiomyopathy and really fascinated in the disease, really since I took care of my first patient with it and when I was an intern at the Ann Arbor VA. So I'm going to share with you a number of new insights that we've gleaned over the years, some features of the new guidelines, as well as sort of the future directions that the field is moving in. So first, some disclosures. These are really don't have any relevance to this particular talk, but I do have consulting agreements with MyoKardia, which is now Bristol Myers Squibb, and Tenaya Therapeutics, and receive funding from MyoKardia for the SHARE registry. Probably my biggest disclosure for this talk is that I sort of still consider myself somewhat of a competitive athlete, less so every day, but these pictures, particularly the black and white, tells you how long ago, I was like formerly a competitive athlete on an organized team. This is back at MIT many, many years ago. And then this was a picture more recently, obviously not this year. We didn't get to run this year. This is a relay race that a group of us have been running since the 90s back in Michigan. So, one of the most rewarding things about being in this field are all the people that I have met over the years. It's been 15 years since we started the HCM program at Michigan. And now I'm really fortunate to be in the Center for Inherited Cardiac Disease at Penn. And Adam Helms, who you heard from a few weeks ago, and Sarah Saberi, and I'll talk about some of her work today, are now the leaders of the HCM program at Michigan. And all of the people that I've met collaboratively through research studies, the RESET study, Ewan and Matt and Heidi at Stanford, Rachel, of course, through the LIVE study, Mike Ackerman, and then all my colleagues in the SHARE registry, and I'm going to show you some of the data from SHARE. This has been an incredibly rewarding experience. The SHARE Multicenter International Registry comprises 13 centers across the world. We've accrued 9,554 patients with HCM as of yesterday, and over 5,000 of those are genotype patients, with 2,600 being carrying sarcomere gene mutations. I'm also very grateful for all of the hard work and dedication from our lab-based research team. So my lab's kind of pared down since I moved to Penn, and once we can actually start hiring people again and letting people back in the lab, hopefully that will grow. But I'm still kind of managing a lab back in Michigan as well, with the help of David Ginsberg, who's co-mentoring postdoc and graduate student back there. So many collaborators now, including those from Penn and Penn Vet Cardiology, I'll talk about briefly today as well. And lastly, the patients. I mean, I'm so appreciative and grateful for all the patients who I've been able to share their lives with, and it's been incredibly special to take care of them over the years, and to see how motivated they are to participate in clinical trials to further the field. So one of the patients on this slide said to me, there wouldn't be any research if it wasn't for us, the patients. And so I'm very grateful that I have something to talk about today, because without them, I wouldn't have much to say. So I'm going to cover quite a bit of ground at kind of a high level. I'm going to spend most of the time talking about clinical research and patient and patients. So this is primarily a clinical audience, but I will give you some insight into some of the research studies that we're doing in the laboratory as well. I know Adam spoke a few weeks ago, so I'm not going to spend a lot of time talking about his work, but I'll just give you kind of a glimpse into that at a sort of a high level. So hypertrophic cardiomyopathy is the most common genetic heart condition that's inherited as a Mendelian trait. It's defined sort of simply as unexplained hypertrophy at or exceeding 15 millimeters in any segment. That's, of course, easier said than often diagnosed. But variants in sarcomere genes account for more than 90% of the familial form of hypertrophic cardiomyopathy, but really only 50% of patients who have a clinical diagnosis have an identifiable genetic mutation. So there are a number that are, you know, potentially non-Mendelian disease, like sort of polygenic and acquired factors that contribute to LVH. There's a huge variation in the age of onset and disease severity, such that some patients have no or mild symptoms and normal longevity, while others suffer symptoms of congestive heart failure, atrial fibrillation that can be particularly troublesome to manage, ventricular arrhythmias, of course, that can lead to sudden death. And HCM looks a lot of different ways. I just showed a few of the major morphologies here on the bottom, the asymmetric septal hypertrophy being the most common, but there are also apical variants, midventricular variants that can lead to apical aneurysms. And then outflow tract obstruction is present in about 1/2 to 2/3 of patients and can be a major source of symptoms as well. So overall, when you look at the, you know, sort of the whole spectrum of patients with HCM, there's really a substantial disease burden, where patients with HCM have a 3 to 4-fold higher mortality compared to the general population. These are for the US patients from SHARE compared to the general US population across all age strata. And here's a cumulative incidence plot that looks at the cumulative risk of developing adverse outcomes. This is sort of everything: death, stroke, heart failure, AFib, and ventricular arrhythmias. And you can see that those that are diagnosed at a young age in particular are at very heightened risk of developing at least one adverse complication over the course of their lifetime, close to 90 to 100%. And that sort of the trajectory of those curves is fairly similar. It just sort of starts at a different point depending on when someone is diagnosed. So ventricular arrhythmias or sudden death are obviously the sort of most well-known complication of HCM and most notorious. But you know, for those who are diagnosed later in life, this is really, you know, not much of an issue. So if you're diagnosed over the age of 60, there's less than a 1% lifetime chance of having a ventricular arrhythmia, compared to those that are diagnosed as children or young adults, where they may have a lifetime risk as high as 35%. But heart failure and atrial fibrillation are actually far more prevalent across all age groups of patients with HCM, but often take many years to decades to develop from the time of diagnosis. Patients with sarcomere gene mutations tend to have a higher rate of events, and that is, you know, something that we've been able to demonstrate through the SHARE registry. When we compare, this is now sort of a Kaplan-Meier curve of the same composite endpoint, the overall composite endpoint, where patients with sarcomere gene mutations, here shown in green, have a much higher prevalence of adverse outcomes compared to those in red. And then patients that carry variants of uncertain significance fall right square in the middle. And that's probably because VUSs are kind of a mixture of benign and pathogenic variants that we can't yet parse out. And if you look across all the different individual outcomes, patients with sarcomere gene mutations, really across most of the individual outcomes, have a higher risk of events compared to sarcomere negative. Now, there are also a lot of non-genetic factors that we've identified as being predictive of adverse outcomes, and most of them have been predictive of heart failure. We really haven't found anything other than genetics and the traditional risk factors that predict risk of sudden death. But here, this is looking at adverse outcomes in obese patients. So obesity is definitely a risk factor in HCM for developing complications from HCM, and that's really been driven primarily by a higher rate of heart failure. We've also seen a higher rate of heart failure in Black patients with hypertrophic cardiomyopathy, where the hazard ratio is about 2-fold that to white patients. Now, we don't have a huge number of patients who are Black in our registry, and that's clearly an area where we need more data. This is data recently published by Neil Lakdawala from the SHARE registry, looking at sex as a biologic variable in HCM. And women with HCM tend to, first of all, are underrepresented underrepresented overall. They tend to be diagnosed at a later age, and they do have a higher rate of heart failure and also higher mortality compared to men. And the reason for this is unclear. We think it's probably a combination of lack of referral bias, as well as potentially some other biologic factors that are yet to be defined. So for those of you that don't take care of HCM patients, I thought it might be informative to hear what it's like to live with HCM. And so I'm going to show you a 3-minute video clip from someone named Wendy Borsari, who some of you probably know. She is a patient with HCM, but also a very strong patient advocate and educator. And I think, you know, this is, first of all, I have to apologize for the very amateur editing of the video, which was me. But I think it will give you a glimpse into sort of into what it's like to live with this disease. So I'm just going to have you listen for a few minutes.
I was diagnosed with hypertrophic cardiomyopathy at the age of 24. So she sent me to a cardiologist who had never heard of or never worked with anyone with hypertrophic cardiomyopathy. And during the appointment, she got out her medical book and read to me what it was from her medical book. And at that point, she told me, you know, you could drop dead at any moment from sudden cardiac death. You shouldn't drive. You will never be able to have children. And kind of essentially, you know, almost stop living your life. Just sit back and wait for this to kill you, sort of thing. My mother had lost 4 brothers to sudden cardiac arrest. And because I had these near fainting episodes that they couldn't really pinpoint exactly what had happened during those, they thought it was safer to go ahead and just put the implant in. I mean, I have good days and I have bad days. So I have days where I just don't even, if I didn't also work with HCM, I'd probably forget that I had it. But then I have, you know, I'll have a bad day where pushing a grocery cart, an empty grocery cart, across the parking lot of a grocery store, you know, I struggle to do that. And my daughter was diagnosed at birth, and my son then was later diagnosed at the age of 15, but he has almost no symptoms, very, very mild thickening, has absolutely no restrictions, does all the exercise, you know, everything he wants to do. And my daughter, on the other hand, she had surgery right after kindergarten. About 9 years later, she suffered a series of cardiac arrests. In terms of the exercise and you know, and my kids, I had worked with enough other people, patients with HCM who had teenagers already when my kids were little, who had to take these things away from their kids. You know, the kid was the star football player and, you know, getting ready to go to college and get the scholarship, and suddenly they couldn't play football anymore. So the restrictions in my mind made sense because, you know, that's just what the standard operating procedure kind of was at that point. Luckily, both of our kids are really nerdy, so neither of them really wanted to be in sports. So both of my kids are madly into exercise now. Her heart is not in good shape otherwise. And, you know, the chances of her needing a transplant with how many we've already had in the family are probably fairly significant. But I know she would be going into that as healthy as she could possibly be. Miss a day of exercise and we all get a little grumpy. My mother, who had HCM, had this idea that, you know, knowledge and science were the key to everything. I was asked to speak in front of Harvard and MIT classes for my cardiologist, Christine Seidemann, when she would teach these classes on genetics. This was when my son was a newborn baby, so I would bring him in the sling to the class with me, or in the stroller, or she would walk around the class with him while I answered questions. I think it's really important for patients to use their voice. HCM can make you feel very out of control.
So I hope you all enjoy listening to Wendy. She is a wonderful person, and I think she brought home a lot of points that are really important that all of us who care for patients with HCM grapple with every day. There are so many misconceptions out there. You know, this is not of historical interest. This still exists, and you know, there's a lot of fear around this diagnosis, and patients come to our clinic having just been diagnosed and are very scared that they're going to drop dead or something horrible is going to happen to them. And you know, so it is, you know, so a lot of what we do is we spend time, you know, dispelling those misconceptions and reassuring patients. But we need to change that. And, so hopefully, some of the data that we're accumulating will start to get out there into the public. There's a lot of day-to-day fluctuation in symptom burden that we don't really have a good explanation for. I mean, sometimes you can pin it on, poor sleep or hydration or something, but it's often really, the sort of day-to-day variation is really perplexing a lot of the time. And you could, hear from her the huge spectrum of disease to severity, even in the same family. So her daughter is somebody who may be headed to transplant, and but her son has very mild disease and was diagnosed later. So clearly there are disease modifiers, both genetic and non-genetic, that we just haven't defined yet, but they must be there. We've heard from her that exercise and quality of life are really important, not surprisingly, to patients. We heard that education is really bidirectional, and we need to listen carefully to our patients as much as we need to educate them. And the patient should feel empowered to speak up and to participate in decisions around their management. And these tenets really, I think, embody the new guidelines. And so this is my transition into the update from the 2020 ACC guidelines that are really centered around shared decision-making. And the reason that this was really the heading in all the news stories about the guidelines is that we really felt like we needed a different approach than one that's been historically taken. I think the guidelines in HCM in particular have been very paternalistic and dogmatic in terms of making recommendations to patients of what they should do and how they should live their life. So this was really a central component that really infiltrated sort of all of the guidelines within all of the sections. So multidisciplinary HCM centers were also featured in this guideline, and this is new. And the reason we felt this was important was because, these centers have been in existence for a long time. There really have been no sort of peer-based criteria for when a patient should be referred, what constitutes sort of a specialized center in caring for patients with HCM, and what are the metrics that should be kind of used to determine whether a center, should be one, for example, that does septal reduction therapy. So there's a couple tables in there. I haven't, the entire table would be too big to put in this talk. This is just the heading, but this table shows the suggested competencies of what we called comprehensive and primary HCM centers, and when patients should be considered for referral. In general, referral should be considered for very complex disease-related management decisions, particularly those that are specialized to HCM. And then there were some metrics that we put forth for septal reduction therapies as well. So sudden death risk stratification had some modifications with this guideline as well. There were some conventional risk factors that held up pretty nicely over time. So aborted cardiac arrest obviously is a class 1 indication, hypertrophic burden and non-sustained VT family history and non-vagal syncope are all of the classic risk factors that have stood the test of time. Non-sustained VT was downgraded a little bit to 2B for adults because it really depends on the rate and frequency and duration. Rachel can tell you more about that. The European risk score was new since the previous guideline document, as it was incorporated into this as sort of part of the discussion. This estimates 5-year risk of sudden death and uses conventional risk factors as well as age and left atrial size and gradient. There is an app for that, so if you don't have this already and you're interested, this is where you can find the app and you can enter data, patient data, and come up with a score. Novel risk factors were also incorporated into this guideline. LGE burden is something we still sort of grapple with and are not quite sure how to incorporate, but that we consider that a class B recommendation for sort of extensive burden. How we define that is still, I think, up for grabs, but a lot of people are using 15% as kind of a cutoff for the total LGE to total mass, LV mass. These data, I think, were helpful in crafting that recommendation, and that is that these are patients that are in an intermediate risk group based on the European risk score, and whether or not they had obstruction or not, if they had LGE that was greater than 15%, they seem to have a higher rate of ventricular arrhythmias compared to those that had a lesser LGE. So this hopefully will be settled a bit more definitively when the data from the HCMR study comes out, hopefully in 2021. The other new class 2A risk factors were EF less than 50% and apical aneurysm, which is a rare complication, typically with the midventricular morphology, but one that seems to portend a higher risk of ventricular arrhythmias and potentially stroke as well. So genetic evaluation and testing was highly featured in this guideline. There are actually 9 class 1 recommendations for genetic evaluation. I just highlighted the top 2, which are 3-generation pedigree and genetic testing to be offered to patients, as well as to family members for cascade testing. And there's this nice flow chart that kind of tells you how to work through a case where you do targeted gene testing, and depending on the results, where you go from there in terms of cascade testing and clinical surveillance for the families, with lots of tables that kind of break down the recommendations into a more granular format. Lifestyle considerations were also a section that was heavily modified compared to previous guidelines. And there were a lot of additions to this particular guideline. So it wasn't just about exercise. We also had recommendations for pregnancy, for occupation, as well as management of comorbidities. So I'm going to spend more time on the exercise, but just to highlight the new class 1 recommendation here was for patients with HCM to engage in mild to moderate intensity recreational exercise, both for benefit related to their own physical functioning, quality of life, and cardiorespiratory fitness and overall health, sort of in keeping with what we recommend for people in the general population. For pregnancy, there were a number of class 1 recommendations for once somebody becomes pregnant, what you should do, and a 2A recommendation for women who wish to become pregnant, so it's reasonable to advise them that pregnancy is generally safe. And this is really true, that the complications with pregnancy are exceedingly rare. And management of comorbidities, we really felt like we needed to call out, although it seems fairly obvious that people should lose weight, maintain a healthy body weight, exercise, control their blood pressure, and be screened for sleep disorder breathing. But these are complications we see very, very commonly in the HCM population. Actually, about 70% of HCM patients are either overweight or obese. And it's very clear that it's contributing to their symptom burden and to their risk of heart failure. So we just wanted to call this out to make sure that people were really thinking about management as part of symptom relief in patients with HCM. So I'm going to focus for the next few minutes on exercise. And obviously, as Rachel said, this has been something I've been very involved in and passionate about, really since I started the program, because there really were just no data. I mean, this was, as Rachel said, a completely data-free zone, 15 years ago. That was really our motivation for the RESET study, which was a randomized trial of exercise training. This is moderate intensity exercise training, nothing particularly strenuous at all. Most people were walking, using elliptical trainer or a bike. We randomized between Michigan and Stanford 136 patients to either usual activity or an exercise training program. And what we saw was an absolute increase in peak VO2, which was our primary endpoint, of 6%. Or 1.27 mils per kilo per minute, which was statistically significant and probably based on data from heart failure like HF Action. This is probably a clinically meaningful increase in exercise capacity. Patients also felt better. They had an 8-point increase in the SF-36 on their physical functioning score. So I think that that was meaningful. And importantly, we didn't see any major adverse events, and we had really no increase whatsoever in arrhythmic events. There was actually a decrease in PVC burden in those that were in the exercise training arm. So we were very pleased at the results, and this was clearly one of the trials that supported that class 1 recommendation for patients to engage in recreational moderate intensity exercise. So this was also a major departure from the previous guidelines, were recommendations around vigorous exercise and competitive sports. This generated, as you might imagine, an enormous amount of discussion.
Weekly updates. I'm like, we're carrying avocado.
I think someone needs to go on mute. Maybe Christine's.
I think 17, 18.
Yeah. Okay. So we had 2 recommendations around this. So the first was a class 1 recommendation that for athletes with HCM, you should talk to them about it, right? So that seems, again, obvious. But again, this is sort of part of the whole shared decision-making process. And then a 2B recommendation that participation in high-intensity recreational or vigorous competitive sports could be considered with a lot of qualifiers, right? So this is not a one-and-done recommendation. This is comprehensive evaluation. This takes hours and often multiple visits. a shared discussion, repeated annually, so important that they're following up, that they're getting, continuing to be evaluated on a regular basis, including monitoring and so forth, MRIs. And it's important that we convey that there's uncertainty around this area, that we don't know for sure whether their participation could increase their risk of sudden death or ICD shocks. And we also acknowledge that eligibility decisions around competitive sports often involve third parties that are acting on behalf of the schools or teams. And so we may endorse, their decision, but ultimately they may not be allowed to compete depending on what these third parties decide. So this is sort of the overall scheme that I think the guidelines support, and that is actively encouraging patients to participate in recreational exercise and the shared decision-making around vigorous sports. So in addition to patient, to sort of in supporting patient autonomy, that was sort of the spirit of this 2B recommendation, we were also spent a lot of time discussing where the data are at in terms of, whether exercise actually increases risk of sudden death. And I think now that there are a number of studies, and I believe Rachel will agree with me here, that suggests that the risks of exercise in sports are maybe not that high. If you look at the annual incidence of sudden cardiac arrest or death in patients with HCM, it's exceedingly low. So we're talking about a very rare complication to begin with. And then this idea that HCM is the most common cause of sudden cardiac arrest in young people, I think has been well dispelled now from a number of studies that show that HCM accounts for, in many cases, fewer than 10% of all sudden deaths in young people. Maybe up to 20% is the highest that I've seen in contemporary studies. And most events also occur during routine daily activities like at rest or while sleeping. And actually very few shown in here, I'm highlighting two studies, one from Chris Msarian's group in Australia and another one recently published in Circulation. Minority events occur during exercise. So they really occur much more randomly. Here's a couple of studies in small numbers, but of those that have looked at athletes with HCM or other genetic heart conditions who have decided to stop playing or have continued to play. And these two graphs actually show trends in the other direction, which was that those athletes that stopped playing actually had a higher rate of arrhythmic events, which you may not have expected. This is a study from Mike Ackerman, and only 23 of these athletes had HCM. A large percentage of them had long QT and other channelopathies. But the data, this is early, but I think at least it's not showing a harmful trend that we would be concerned about. And we certainly need more data around prospective data around athletes. These are data from Rachel and from the ICD Sports Registry of the 440 athletes that participated in the ICD Sports Registry. 75% of them had HCM. And overall in the study, there were no deaths, resuscitated arrests, or shock-related injuries. Patients did experience more shocks during physical activity overall, but there was no difference between competition and practice versus kind of low-level physical activity that they were doing kind of around their, in their daily life. And this held true for the HCM cohort. And the rates of shocks were similar to those reported for less active ICD populations. There wasn't sort of a control group per se. There are also some circumstantial evidence that vigorous exercise may actually be good for patients with HCM. This is a retrospective study and a survey-based study with all of its inherent limitations, but showed that vigorous exercise in patients with HCM correlated with better diastolic function, increased cavity size and stroke volumes, and reduced symptom burden. And there was no difference in the occurrence of ventricular arrhythmias between those who were considered athletes versus non-athletes. So obviously we don't know whether people that exercise more vigorously may just have had less severe disease to begin with. So there are a lot of caveats around this, but I think it's somewhat encouraging. And then clearly we need more data. And this is where, I've gotten to know Rachel the best over the past, I don't know how many years, I guess it's been more than 5 years now since we started this study. This is the LIVE study. There are companion studies in HCM and long QT, where we've now enrolled more than 2,000 patients in each study, ages 8 to 60. And so this is an observational study where we are looking at clinical outcomes and quality of life across all different levels of exercise. We have, looking at the baseline data, there are a number of patients who are very active, either recreationally or competitively, which makes sense because they're going to people who want to enroll in a study about exercise if they are interested in exercise. But we do have a number who are less active, and we'll be able to compare clinical outcomes across a whole range of levels of exercise and activity. So we expect that we should have the follow-up completed.
I'm on the science experiment.
I think there's someone still who needs to go on mute.
Oh, sorry. It should be fine.
Okay. So, you know, we can't very easily do a trial of vigorous or competitive sports in people, but we can do it in mice. And this was, I'm just going to show you a few slides from a student who, an MSTP student in my lab at Michigan, who I'm still working with, who came to me with the idea of doing a high intensity exercise training study in mice with HCM as a way of sort of gathering more data, obviously recognizing mice aren't humans, you know, but we might be able to answer some questions in an animal model that we can't readily answer in patients. So we chose to use a mouse model that was generated by Jill Tardif at the University of Arizona. This is a mouse that carries a mutation in troponin T that replaces the endogenous troponin T. So very similar ratio to what you would see in patients. So at baseline, they actually don't get hypertrophy, and that's true of a lot of the mouse models of HCM for reasons that aren't entirely clear, but it probably isn't that important because they do show other features of HCM that we see in patients. So they have smaller LV cavities, they have higher ejection fraction, so they're somewhat hypercontractile. And they also have increase in their left atrial weight. These are post-mortem data where these were echo data. So both in females and males, we see that their left atrial weights are about twice as much as their non-transgenic counterparts. So that's really reflecting the diastolic dysfunction and restrictive filling like we see in patients. So Jonathan is characterized through their baseline exercise capacity in these mice. And here shown is, there's two ways that he did this. One was on a treadmill. This is very similar to what we would do in patients, except you know, we can't put a mask on a mouse or a mouthpiece. So what we do is it's an enclosed chamber, so we can measure their oxygen consumption in the whole chamber. And it's actually like a really similar to a stress test in humans, except there's a shock grid at the back. So we don't let them stay on it too long, so we don't. And this is all approved by the Animal Use Committee. So, so here we looked at peak VO2 in non-transgenic females, transgenic females, and males. Same. And we only saw like a trend for a deficit in transgenic males, but when we used a different training modality, this is called a rotarod, where the mice like run on a rod, and then basically they don't fall that far, but then when they fall off, that's basically when the test ends. And so we can measure how fast they can accelerate. And so both the female and male transgenic mice had lower acceleration capacity compared to their non-transgenic counterparts. So then Jonathan has developed this training protocol that really didn't exist before. It's based on what we do for humans in high intensity exercise training protocols. So it's like the 4x4s. We do 4 minutes of intense, 2 minutes of recovery, 4 minutes intense. You do that 4 times. So it's 31 minutes total, 3 times a week for 6 weeks. And that's the training stimulus that they had. And when he looked at the end of that 6-week period, we saw significant increases in peak VO2 in both the non-transgenic and transgenic group. These are now, sexes are grouped here, but it was similar in both male and female. And we saw significant increases as well in acceleration and endurance as measured on the rotarod. So the training stimulus was really quite significant, and nothing bad happened to any of the mice. You know, they didn't die. They all were able to make it through just fine. So, you know, one of the things that we can look at in animal models that we can't readily look at in humans is whether exercise could actually be a beneficial disease modifier. And one of the ways we think that it might do that is by improving cardiac metabolism in HCM. And I won't belabor all of the signaling pathways here, but exercise is known to improve the oxidation of fatty acids, which is the primary fuel source that the heart uses, as well as mitochondrial biogenesis. And it's actually been known for quite a long time that HCM is an energetically deficient state. So these are 17-year-old data that used phospho-31 MR spectroscopy to look at the phosphocreatine, which is the primary energy store, to ATP ratio. And so a reduction in this ratio is considered like an energy depleted state. So these are patients with HCM compared to controls, and there was a significant reduction. But interestingly, even patients that carried a gene mutation that had no LVH, so we consider these genotype positive, phenotype negative, or preclinical disease, they had the same decrease, suggesting that this may be sort of an early phenotype even before the disease overtly manifests. And there have been a couple of trials now looking at metabolic modulators with the idea that you could shift this sort of fuel source from fatty acids maybe over to glucose by inhibiting fatty acid oxidation. And so there was one trial of perhexylene which looked promising, but the drug was too toxic and had hepatic and renal toxicity. And this trial was with trimetazidine. This was just published last year in JAMA Cardiology. And it actually showed a trend in the wrong direction, which was that patients on the drug actually had a significant decrease in their exercise capacity and 6-minute walk. So this was somewhat discouraging, but I think that what we really need to understand is what this metabolic deficit is more precisely. So we know that the healthy heart uses primarily fatty acids. This is fatty, sorry, I somehow cut this up. This is supposed to be fatty acids in pink relative to glucose, but it's also important that it maintains the metabolic flexibility and can actually use multiple sources. These are some really nice data from Zoltarani's group here at Penn that was just published in Science a month or so ago, where they took patients from the EP lab who were having atrial fibrillation ablations and sampled blood in the artery, vein, and the coronary sinus simultaneously. And so you can, from that, you can analyze the metabolites and figure out what the heart is using as a fuel source. And so here is PEF is not heart failure with preserved ejection fraction. It's actually just non-failing hearts. These are patients with AFib that did not have heart failure. Primarily, they're using free fatty acids, and a minority are using like ketones, amino acids, and lactate. For those patients that had heart failure with reduced ejection fraction, they use less fatty acids, but what we think is an adaptive response actually use more ketone bodies, lactate, and amino acids. So we were interested in understanding what what the metabolic defect is relative to these different fuel sources in HCM. So we haven't done this study in HCM patients, although we're contemplating doing that now. But what we have done is analyzed the metabolites from HCM hearts that we've obtained from patients who had septal myectomies. So we broke them up into 3 groups according to their genotype, no mutation, myosin-binding protein C or myosin, compared to non-failing donors. We had already done a proteomic analysis, and I'm not going to show you the details of that, but I'm just going to show you just a few insights that we've learned from looking at the metabolites in these human hearts. So first of all, we verified that human HCM hearts are energetically compromised. There's a decrease in ATP really across all 3 groups. And one thing that was fairly remarkable in all the metabolites we looked at is it seemed to be genotype independent. So regardless of what the underlying genotype was, we saw really similar changes. And there was a decrease as well in what we call the energy charge, which is calculated here as shown below. And primarily, we think that's due to depletion of long-chain fatty acids, which again are the primary fuel source in the healthy heart, but are really severely depleted in patients with HCM. I'm just showing you a few of many of the long-chain fatty acids. And that matched up nicely with our proteomics data set. These are just a few enzymes I'm highlighting that have a very significant, these are p-values, 30 to 40% reduction in patients with HCM. So we think there's a depletion in fatty acid metabolites because of this decrease in the expression of the enzymes that metabolize fatty acids. What we also saw was interesting and is also seen in heart failure are an increase in ketone bodies. So this is one of the 3 ketone bodies here that's increased, and this is one of its metabolites. And this is an observation that's been made in patients with end-stage failing hearts, but here we're observing very similar profile in patients with HCM who are relatively well compensated and are certainly not in end-stage heart failure. And this has been shown to be an adaptive response and one that could be potentially leveraged therapeutically to increase the fuel sort of source of ketone bodies for the heart. So we think this is maybe a very promising direction that we're exploring right now. So just in terms of thinking about kind of the roadmap, like where are the next steps? I think of HCM is starting with some inciting factor, a mutation primarily, but there may be other, polygenic and other acquired factors that could incite some primary biophysical effects that eventually lead to remodeling and then to all the complications that you see with HCM. And we know there's modifiers, that clearly the penetrance increases with age. Males seem to have a greater penetrance than females. And there are also genetic and lifestyle modifiers, many of which haven't been well defined, but we know exist. When we look at where we are with established therapies, we've made huge strides. But we're still really on the very right side of this sequence, right? So we're really treating the complications from the disease and not necessarily preventing them or treating the underlying disease itself. So this is the focus of research, right? Of where we are and trying to move earlier in the process. So there's been some data from Carolyn Ho with calcium channel blockers, with angiotensin receptor blockers. We're still waiting on the VANISH trial results, which are being analyzed right now. And I think it's very possible that there'll be some combination of pharmacologic and lifestyle therapy that will include exercise, maybe metabolic modulators, sort of is yet to be seen. And I think a very exciting area right now, and Dan Jacoby at Yale has been very involved in these trials of Mavacamten. These are myosin modulators that dampen contraction by binding to myosin and decreasing the ATPase turnover rate. And I'm going to highlight just a couple of trials that I'm sure many of you have heard of, the Explore and MAVERICK trials that have shown significant promise. And then, of course, if we move even earlier, there may be genetically targeted therapies in our future. Some of that may be gene replacement or gene editing, but I think we could also think about ways in which we can kind of target the effects of the mutation without actually employing gene therapy. So I'm sure many of you are familiar with the results of the Explorer trial. Mavacamten was shown to be very beneficial for treating symptomatic obstructive HCM. This was a randomized double-blind trial of 250 patients showing marked reduction in resting gradients and provocable gradients, as well as significant improvements in peak VO2 and NYHA class. This is a graph of NYHA class showing those on Mavacamten at baseline. All were symptomatic at baseline and 50% were asymptomatic by the end of the trial compared to 21% on placebo. So overall, 37% in the Mavacamten group met a primary endpoint, which was a combination of the VO2 and NYHA class compared to 17% in the placebo group. So this is now, Mavacamten will be submitted for FDA approval in early 2021. So we're all hopeful that it will be available sometime next year. So Mavacamten was also tested in non-obstructive HCM in a smaller and earlier phase study where 60 patients were randomized to placebo lower high dose. So there was no significant difference in peak VO2 or NYHA class. So the trial did not meet its primary endpoint. But there was a signal that there was some potential benefit here and that the NT-proBNP was decreased in the Mavacamten compared to the placebo group by about 50%. So, more to come on that. And I think there will be a phase 3 trial coming in 2021. So in the last few minutes, I'm just going to share a little bit of our lab-based research program with you. And I know Adam was here giving grand rounds a few weeks ago, and I'm sure he spent quite a bit of time talking about the iPS cell cardiac myocyte models. This is something that he spearheaded in my lab when he first started. And so this is a really powerful technology that allows us to take patient-derived somatic cells and reprogram them and then turn them into cardiac myocytes so we can study them. And he's developed some really nice micropatterning techniques to look at either single cells or multicellular preparations, which allows us to look at kind of the alignment and morphology of the cells really cleanly. And he probably talked about myosin binding protein C, which has been a focus of our lab for some time. It's the most commonly mutated gene in HCM. It's a protein that regulates thick and thin filament contraction. And that most of the mutations in myosin binding protein C are truncating mutations, so they result in a premature termination codon. We have shown through work using human tissue in collaboration with Mike Previs at the University of Vermont, that myosin binding protein C reduces the amount of, the variance, truncating variants in myosin binding protein C result in about a 40% reduction in protein in patient samples. These are again from myectomy samples, and we don't see any expression of truncated peptides. So one of the things that we've been thinking about therapeutically in terms of, this is sort of on that far left side of the curve, the genetically targeted therapy side, is whether we could in some way reverse the haploinsufficiency. So could we make the wild type allele make up for this reduction in protein that's happening because of the mutation on the other allele? So Andrea Thompson, who's a cardiology fellow and on the T32 and MD PhD in chemical biology, when she joined my lab, had the idea to do a high throughput screen in iPS cell cardiac myocytes to identify compounds that regulate the protein. So the idea is that we're going to try and probably stabilize the wild type protein to try to restore normal levels. So we designed this assay. I won't go into details, but it basically is a really nice assay that you can use in a high throughput format that's very sensitive to detect the amount of protein in your preparation. And she screened a 2,400 compound library of FDA approved drugs, as well as adding in 42 candidate compounds. And so this graph shows you kind of the results, overall results, where she had really tight values for the vehicle treated cells, and then there were some potential hits in red triangles that were both above 3 standard deviations or below 3 standard deviations from vehicle. There were potential hits that changed the level of myosin binding protein C, and of those, after extensive validation, secondary testing, there were only 2 compounds that we found, and both of them decreased levels of myosin binding protein C. So opposite to what we want to do therapeutically, but something that potentially we could exploit if we understood the pathway. So one of those pathways is called the HSP70 chaperone. So this is the chaperones are proteins in cardiac myocytes and in all cells in the body that help to proteins to fold and also facilitate their degradation. So they're very important for protein turnover. And HSP70 is very ubiquitous and well-known, has a lot of clients. And one of the compounds that we tested was called JG98. And JG98 interrupts interactions with HSP70 with BAG3, which is one of the nucleotide exchange factors, such that when cells are treated with it, any clients are facilitated, the client proteins are facilitated for degradation. So we did find a decrease in myosin binding protein C with the use of JG98 relative to myosin. We showed through an assay where we can track the protein half-life that JG98 is actually decreasing or speeding, accelerating degradation. And it did so without any cell toxicity. And we had found previously that HSP70 was an important and very strong interactor with myosin binding protein C. And that one of the isoforms localizes to the sarcomere, like really basically juxtaposed right between the bands of where myosin binding protein C is located. And we showed through various sort of knockdown and other approaches that myosin binding protein C was clearly a client for HSP70. So really our next step at this point is to try and identify the specific components of this network, because we can't target HSP70 as a whole because it's too ubiquitous. And it has too many other clients. So we're going to try and hone in on specific co-chaperones that may make it more selective. So finally, I just I want to acknowledge the many limitations of experimental model systems to study HCM. So iPS cell derived cardiac myocytes will have been a major advance. We know that they're still very finicky. There's a lot of batch-to-batch variability. They're immature. Sometimes they don't differentiate for reasons that nobody can understand. And then there's issues with comparing patient-derived lines to control lines, and that there's a lot of other genetic background to contend with. And we also know that we've used mice for many, many years, but mice aren't humans. Many features of HCM aren't recapitulated. Often the disease comes on very late or very mild phenotypes, even at late ages. They don't get spontaneous arrhythmias. They mostly don't get hypertrophy. So, we really, need to think about other ways in which we could, other preclinical models to study HCM. So I'm just going to share with you for the last minute or so something I've been very excited about since coming to Penn, which is a collaboration with the Penn Vet program here. Mark Oyama has been really spearheading this. We've now established a cat organ donation program. And many of you may be surprised, as I was, to learn that 1 in 7 adult cats have HCM. So this is not like a purposely bred cat model. These are cats in people's homes. And these are just mixed breed house cats, and it's incredibly common and a big issue. So they have a huge clinical practice at Penn Vet of cats with HCM, and they really have no treatment options for them. So we've struck up this collaboration. We have started to harvest organs from cats in a similar way in which we would procure organs from humans. Here's an echo from a cat from a heart that we got last week. So this is in 2018, shows the typical hypertrophy, hyperdynamic function. Here is its echo a couple days before it was euthanized for end-stage heart failure. You can see that the hypertrophy is regressed and that the atrium has gotten ginormous. These cats do develop left atrial thrombi, as patients do. They actually don't get AFib, oddly enough. Here's a video of the heart during the procurement. You can see the thrombus in the postmortem. And then we were able to isolate myocytes from the heart, and we can show here very preliminarily with only 5 myocytes from this heart, but compared to historical controls from a non-failing cat heart, they do show reduced contractility. So, we're very excited about learning about how the cat HCM is similar to humans, or ways in which may be different at this level, but we also think there's a huge amount of potential for doing clinical trials in cats at the vet school. And both for testing known compounds like Mavacamten, as well as for testing novel compounds that we're developing in our research programs. In closing, we have known about HCM as a clinical entity for more than 50 years, and we've known the genetic basis for about 30 years. But there's still a lot that we have to learn in between, and particularly thinking about where is the opportunity for disease modifying intervention. I think it's likely to be very early, but there are a lot of challenges to implementing therapies at such an early stage. We don't know yet what treatments those will be, whether they're going to be individualized or more generalized to treat patients across a variety of different genotypes. When do we start them? And how long are we going to treat them for? This is a lifelong disease that progresses over years to decades. So balancing potential side effects of any treatment that would have to be implemented probably long-term, and how would we measure efficacy in a reasonable time frame when the disease progresses at such a slow and nonlinear rate. So many challenges, but I think an incredibly exciting time to be in the field, and a lot of things that I expect, a lot of new insights and new therapies that we'll see in the coming years. So thank you all for your attention. I'd be happy to take questions.
Any questions for Dr. Day? Sharlene, let me start with a question then. First of all, let me congratulate you for a great talk and a great body of work. And I'd also like to specifically congratulate you for the RESET study, which really was such a radical change in paradigm to show that patients with HCM, first of all, can increase their fitness levels and that they can do it safely. So my question is, the LIVE HCM study will look in an epidemiological fashion about vigorous exercise, but I wonder if there's any plans to look in that very detailed physiologic phenotyping type of manner at more vigorous exercise.
Yeah, well, we've talked about this, obviously. It's a hard thing to do, again, because of the time frame and then, the collection of data. And we look at echoes, which are pretty low resolution when you think about it, right, to look at disease progression. It's a really hard question to answer. It's one of the reasons that we wanted to look in the, in animal models, because we can control it better and we can, kind of compress things. But I think it's a really critical question. I've not seen any data that suggest that exercise is harmful in terms of the remodeling process. So I think it remains to be seen, and I think it's something we need to do, but it's a difficult study to design. So you and I will have to keep thinking about it.
I have a question, Rachel. Sharlene, this is Jeff Bender. That was incredible. That was wonderful, and congratulations for all your work.
Thank you so much.
I'm going to try to see if I can simplify this question so that even I can understand my own question. So there are a few concepts. One you've mentioned, and we all know the variable penetrance of the disease, even within a family with the same mutation.
Yeah.
So that's always a bit perplexing. And one thing you mentioned towards the end is maybe a little bit of the stoichiometry between the wild type allele or protein and the mutant allele or protein. And that we don't talk about a lot.
Yep.
We talk about the mutation, and since these are mostly autosomal dominant diseases, then there should be some sort of relationship between the wild type and the mutant allele. You talked about modifying that a little bit. One thing that I wondered, so then the other concept is exercise, and you talked about metabolic shifts with exercise, but the other thing that we know exercise can influence is chromatin structure. So epigenetic features of the gene or the chromosome. So I'm wondering if there's any thought that there might be an epigenetic influence within a family that could be different from individual to individual that might result in the change. Again, we talk about open and closed chromatin, but could there be an influence in the structure of the chromatin that the wild type allele may be more accessible than the mutant allele? And is there a way to influence that?
Yeah,
I apologize for the very long question.
There's a lot in that question. We could probably have an hour conversation about that. So so I mean, certainly exercise has a lot of other benefits in general. I mean, I'm pointing out the metabolism just because I wanted to show our metabolic data, and I think that it's, it could be a major way in which exercise could promote disease, either regression or sort of halt progression. Epigenetics, I think, is a fascinating area that is completely unexplored in HCM. I'm not quite sure how to tackle it. I can tell you just anecdotally, I have a family who, the father has HCM and very severe disease, was diagnosed as a child, has had multiple shocks with defibrillator, has systolic dysfunction. He has identical twin boys, proven identical. One born HCM, has substantial disease burden. He's asymptomatic, but has a defibrillator now. The other has absolutely nothing, right? They're genetically identical. So we know there are epigenetic modifiers. It's not my area of study. I don't quite know how to do it. But if you have any ideas, I would love to hear them, because I definitely think there's something there to epigenetic printing, and which may have implications to, when you apply therapy. I mean, maybe it's that, maybe the therapy is like in the womb, right? And then maybe it doesn't need to be lifelong. So I think there's a lot of really interesting questions there. And penetrant, and as far as the allele stoichiometry, yes, I think, we've shown this, like we published a paper about, I don't know, maybe 6 years ago. Adam Helms was the first author on it, where we looked at the stoichiometry, and it's not 50-50 for a lot of the missense mutations. Some of them it is, but some of them it's like 80-20. So I think that probably, that sort of gene dose effect probably has something to do with penetrance and disease severity.
Thank you.
Sure.
Barry Zara, thank you for a wonderful talk.
Thank you.
I was wondering about the issue of metabolic heterogeneity in the hypertrophic heart.
Yeah.
Your tissue data come entirely from the septum at the time of myectomy, where you might have the most exaggerated metabolic abnormalities.
Yep.
Any data from spectroscopy or imaging that might give you a hint about the rest of the heart?
Yeah, that's a great idea. And we're talking now about, I'm like in a hotbed of cardiac metabolism here at Penn. And there are a number of people that are developing novel tracers to look for, to look at metabolic substrates in hearts of patients through imaging. So I don't have the answer for you yet, but I think that's a great question. I definitely think there will be some heterogeneity where you'll see differences in the hypertrophied versus less hypertrophied segments of the heart. But I don't have any information. If we look in patients that have been transplanted with HCM, just the things we've looked at so far, we've sampled different regions and it doesn't look to be any different. But the problem then is that by the time they get to transplant, it's less asymmetric. They've had a lot of wall thinning. So I think things have really changed dramatically compared to the more kind of traditional compensated state.
Thank you.
Dr. Ray, this is Tomar, one of the cardiology fellow. I have a quick question. Can you comment on role of CRISPR in HCM?
The role of CRISPR. So you mean therapeutically or as a research?
Therapeutically.
Yeah. I guess I'm a bit skeptical, to be honest, because I just think there are so many hurdles, both to gene replacement and gene editing therapy, particularly in a disease that is not uniformly fatal. you know, where the potential for off-target effects, you know, having major implications in patients who otherwise can live pretty good lives. You know, in the vast majority of patients with HCM with heterozygous mutations, you know, they don't do all that badly. Obviously, there's a subset that progress, but when would we do the CRISPR editing? You'd have to do it pretty early, right, before the disease manifests, and then subject to, you know, a lot of off-target and other implications, or the viral vector delivery. There's just so many things. So I'm not, you know, certainly there's a lot of promise there, but I think there are a tremendous number of hurdles. So I'm a little bit more excited about, you know, pharmacologic therapy, like, you know, doing small molecule screens to look for things that could modulate the effects of an underlying mutation.
Okay.
Yeah.
Yibeng?
Thank you.
Yes. Sharlene, very nice talk. So it's fascinating to observe the ketone utilization is enhanced in HCM patients.
Yeah.
And we could think give patients more ketone, but ketone may give some side effect. So my question is, do you also observe enhanced glycolysis in HCM patients?
Yeah, I didn't show that data. It's a little complicated. We do see differences in some of the glycolytic intermediates, but it's not quite as straightforward to interpret. So I can share it with you another time, but you know, there probably are differences in terms of the glycolysis, but it's sort of like hit or, it's not all of glycolysis, you know, some things are up and some are down. So hard to interpret.
Any thoughts about the ketone utilization?
Yeah.
To treat
Yeah, I'm actually pretty excited about that. You know, this is a major area in heart failure, and one of the potential mechanisms by which SGLT2 inhibitors work. So yes, so it's something that we're definitely exploring, and I think being able to enhance that already adaptive mechanism to increase ketones as a fuel source could be very promising.
Thank you.
Yep.
Hi, this is Fadi Akar. You know, my question is a little bit of a follow-up on Dr. Zaret's question, but maybe at a more granular level. Mm-hmm. So you highlighted a wonderful talk, by the way. You highlighted the importance of the shift in substrate metabolism in HCM. And so my question has to do with, is this really due to the mutations that cause HCM in the myocytes themselves, or is it in part explained by the changing substrate, if you will, composition of the heart, more fibrosis? And if it's the latter, would you see a similar effect in, you know, an acquired model of heart failure?
Yeah, I don't know the answer. So, but what I can tell you is at least the spectroscopy data suggests that it's early. So it happens before hypertrophy develops, and we don't see fibrosis before we see hypertrophy. So I don't think I think it's an earlier manifestation and not something that requires the presence of hypertrophy or fibrosis. But we also, it looks to be genotype independent, which also means that patients that without sarcomere gene mutations have the same deficit. But I don't know exactly what's inciting their disease. So it's really hard to know kind of what's causing these metabolic deficits. I mean, it clearly there must be there's some metabolic stressor, right, that is manifesting pretty early. And I think could be part of the pathophysiology of the disease. But I really can't answer your question more definitively than that, but I think it's fascinating to think about.
Any other questions for Dr. Day? We are a bit over, but if people have other questions, I'm sure she can spend a few more minutes.
This is Dan Jacoby. I'm sorry, I don't have a question, but I do just want to say what a pleasure it is, Sharlene, to have you here and to hear this wonderful talk. And just being such a leader in the field, it's been a great pleasure and honor to work with you. And thank you for coming and giving this talk to us here.
The honor is mine.
Really appreciate it.
I've enjoyed working with you and Rachel so much, and it really is quite a privilege to be here today. So thank you.
Well, thank you. Thank you for that, all that you're doing in this field. It's really great. So, all right. Well, thanks everyone, and look forward to the next grand rounds. And thanks for joining. Thank you
so much. Bye-bye.